AJ is here to teach us a little bit about the disc FX in just a minute. His daughter Nandini is here as well. So there's your introduction. Go with it.
Yeah, thank you. I appreciate it.
Of course.
So thanks for setting up.
Yeah, I got you. Do the slide we got.
So this, minimally invasive discectomy set, it's probably the smallest surgical discectomy you can do. And so if you have patients who have a small to medium contained disc herniation, for a long time, there wasn't something that filled that niche role. They either weren't a possible candidate because it was too small, a discal pathology, so they weren't a surgical candidate, and they circled the drain, just got on more pain meds, or they weren't ready for a big open spine surgery yet. And there wasn't something that kind of fit that niche role. So that's where I think the Disfix tools are really helpful for that, is you have someone who has a small to medium contained disc herniation, not an extrusion, not a sequestered fragment, and you want to try to do this to decompress the disc, or say they don't have a large disc herniation, but they have gradable annular tears that are causing pain, or they have a communicating channel, and you want to try to seal that tear. This is also a tool set that allows you to do that. You can place a fiber optic, or you can place an endoscope down the cannula. You can take pictures, you can document what you're doing, and you can irrigate and suction. So, a large number of people that have back pain, they have discitis, it's aseptic discitis. And if you can go in and wash that out, they're going to feel a lot better. So some of the famous patients that this has been used on is Oscar Figueroa. He's a 2016 Olympic champion and Disfix patient. He had a lumbar disc herniation, big burly bodybuilder, thrown up a lot of weight and injured himself. And after this procedure, he was able to go back, get stronger, and win a gold medal. So really a phenomenal tale about that.
Guaranteed to win a gold medal if you do this procedure?
Guaranteed.
Guaranteed.
Or your money back, right?
Yeah.
I'm set for Seoul 2020.
Dude, I'm impressed.
So if you, what do I say? Just next slide to move on?
No, you just push the button.
Push the button here.
Right there.
Got it. Okay. So you can see here, we have the anatomic representation of what we're going to do. And you're basically trying to come underneath the nerve root, close to the SAP in Camden's triangle, and that's going to safely enter the disc. And step 1 through step 6 here, basically you're guiding the needle under fluoro. We're going to focus on trying to go after a central disc herniation, which tends to be the hardest. So if you can do a central disc herniation, you can go after others. You insert your needle, and then you insert your guide wire using Seldinger's technique. Your cannula and dilator will go in. You remove your guide wire, and now you're starting to work on the disc. You're debulking it with the pituitary, and then you're using the trigger flex to try to improve the size of your cavity, and you're using the trigger flex to modulate the annulus. Just fluoro images of what it looks like to go in with the pituitary. You can see the grasping forceps there. And then you can also see what it looks like when you stain the disc when you take it out. So we talked about someone with a contained disc herniation, positive annular tear on discogram, or discogenic reproduction of low back pain during a discography, radicular pain. They failed 6 weeks of concerted therapy, and they have appropriate clinical signs and symptoms that match. Who's not a good patient? Someone with a spinal fracture or tumor, infection of the spine, clinical evidence of Cauda equina syndrome, grade 2 listhesis or unstable grade 1. So always get a flexion extension x-ray, make sure you rule that out. Progressive neurologic deficits, allergy to the contrast media or anything else you're using in the procedure. And then again, it's not meant for a sequestered disc or an extrusion. Really, that's a better tool for an endoscopic foraminal approach, and there are tools for that as well.
We have those tools.
Oh, fantastic.
So you can show them off. We're not gonna...
So you have some of the clinical studies that have been done. We can send these out to you. Some fantastic spine surgeons, especially Dr. Hellinger in Germany, where he compared Disfix to his own traditional spine surgery results and found Disfix for the right patient was an advantageous, a minimally invasive, safer, better procedure. So I'll halt there. You guys can there a chance? How do they ask questions? Is there a form?
No last questions at the end.
Yeah,
So let's
okay.
demonstrate your procedure.
All right,
Ready?
let's do it. Yeah, absolutely.
So again, we're using the Biotross model here today, guys, and we have made these discs. In case you haven't tuned in before, One of the things we're able to do at Biotross is modify and fix this to make us the most lifelike experience. Like if you didn't see a minute ago, when I did the loss of resistance for the Medtronic stem, there was like a big woof that went across this because there was that great of a loss of resistance. It's a lot better than like a true cadaver lab where you get in there and just the 3 or 4 people in front of you have taken away all that. So I'm anxious, AJ, to see what you think about the way this feels as you start to insert that in the
Yeah, I'm excited to use it.
I'll
So
be your scrub tech.
thank you very much.
You're an
Dr.
awesome
course.
script tech.
I
You
am.
are qualified for that.
Looking good.
I
All
have
right.
not gone to school.
So I think we've done a good job lining up the end plates here. We can go ahead and oblique over. And what we're going to try to do is put the SAP in the posterior third of the disc. That is traditionally going to give you a very good bullseye route to be able to get your needle into place. So go ahead and keep obliquing over. Yep, keep going. All right. So I think we're at a good position. So we'll use that. Shot 20. Shot again. Yeah, shot there.
There you go.
So you found your point where you want to enter.
Raise the serum just a little bit for me.
Oh, yes.
Thank you.
So it feels like a cadaver. You've got that stiffness there, you know what I mean?
Yeah.
And so that's nice. Yeah, it's got a nice tactile feel to
And
it.
everything holds pretty well.
Right, shot. And so basically you're just trying to grab and push your needle into position.
You guys can see the superior articular process right here.
Shot.
That's where it's
Perfect,
headed
that's
towards.
nice.
Give them the space just above that.
So once we touch down, the beauty of this model is you can see where you are.
Yeah.
You don't get this chance in the cadavers. That's really neat, especially if you're learning. So let's go to
Anthony looked
AP.
good on his
The
intersect. He made it look
yes.
so easy. I think it's the model.
We'll take all the credit.
You know.
We'll take the credit. So AP, what we're looking for here now is where are we in relation to the medial border of the pedicle? And when you start doing these procedures, you want to make sure that you don't go past that. And it also allows you to make sure that you're in the middle of the end plates.
So you're about 50% across the pedicle there.
Right.
Go a little bit more medial.
So on EP, just like, if you do a lot of kyphoplasties, you can go to the medial border of the pedicle
Yep.
and you're going to be safe, right? And so once you've touched down there, you're at a point where you want to switch to a lateral view. You want to make sure that you have now touched this on lateral. Yeah, thank you. And so once you're at the lateral view, you're going to be either in the disc or you're going to be at the posterior border of that annulus.
Do you feel like you're in the disc now?
Yeah. I
Do you
think
feel that feel realistic?
Oh, you're right in the border.
there we go.
You're right at the base.
That's
You're
nice.
right at the annular border,
Right
right
there.
there.
So I think so at this point, in the case we would remove this, and if we wanted to go into the disc and inject a little dye,
Yeah.
you can do that,
Okay.
right? And so here, if we're not injecting dye, we're going to just enter the disc. So yeah, let's take a feel now.
And I think one
Yeah.
reason for that is to make sure there's no extrusion, right? For the dye.
Exactly. And you want to, if you're someone who wants to see nucleus, you want to remove
Like,
nucleus.
Yep.
You want to stain the nucleus. Nucleus is more gelatinous. It's going to absorb the dye, where the annulus won't.
So in the Biotross model here, we're going to pull out foam. So that's the nucleus. So let's see if we're able to pull it out. You
We're
can
going to do
actually,
We're
you
going to
can
do a
actually see it.
foamectomy.
You can
lumbar
actually see it very
foamectomy.
nicely on
Can
the
you build
serum
for
image
that?
even. So you want to go,
We're gonna do
that
CT.
light area is anatomically where the NP would be, the nucleus pulposus would be.
That's right.
So you want to stay right in that light area. The rest of it is,
So now we're safely in disc, right? So we're going to place our guide wire. And here is where we would take, you guys have a scalpel?
we
You have a
don't
little
have a
scalpel?
scalpel.
We'll get a scalpel.
We can dissect down with
Yeah,
the
just
scissors,
sit
yeah.
down.
John, yeah.
We can't trust Chad with a knife, so.
I've been taken away.
Your cutting privileges have
Yes.
been canceled here. All right, super. So I'm going to try to open this up a little bit, just so we have enough room to get our dilator and cannula. It should be pretty easy now.
Good.
So now we're removing, and this is the part where the procedure can get a little dicey. If you have someone who has real soft disc, a very, very well hydrated disc.
You can
'Cause
push through.
Yeah, your guide
Yeah.
wire will move on you,
Yeah.
right? And this model is great. It's keeping everything kind
Do
of.
you feel like
Grab
the viscosity of removal is about the same as what you would normally feel there? It wasn't easy. You had to work at it a little bit.
Yeah, it is pretty viscous.
Yeah.
It's going to grab it, I think, very akin to a cadaver. Yeah, yeah, let's keep
Or
that
even a
in
real
there.
person, maybe.
Right? So here, we have our dilation tool, and that's going to go in our cannula. We slide that together, and we're going to drive that down the guide wire until we get to the annulus. And here, this is the part where you really torque on it. You can really kink your guide wire.
So yeah, you get a little carried away at the front there.
So
Is that
the guide
See,
wire
this is a perfect
advanced a little
example.
bit. Yep.
Of if you're really aggressive and you're not doing it live,
Yeah.
we really recommend that you go in small steps, right?
Yep.
So you just reorient your guide wire back to position, right?
Perfect.
Yep.
And then you continue to kind of just basically soft push, twist. Now, some people get more control when they use a mallet. They're
Okay.
able to mallet it down, and they find that they get more control over that. They're not kind of having to force this as much.
Do you like
There
the
you go.
tactile feel
Nice.
of this?
Very
Where
nice.
you're like, you'd rather do this than hammer it?
I use both, actually. I
Okay.
use both. I think also that just that vibration of hammering for the patient, because we do it under sedation,
Yeah.
Uh-huh.
it actually brings some comfort,
So
maybe a distraction.
You do light sedation?
We do light sedation, yeah.
So just some
Because
Versed and
Your
fentanyl? or-
patient is
Perfect.
the biggest safety mark.
Yeah,
right?
yeah.
So you're close to a nerve root, they're going to be able to tell
They're
you.
gonna tell you, yep.
If
Yeah.
you snow them, they're not going to be able to
Yep,
tell you.
exactly.
So absolutely, we do have surgeons and colleagues who do this under general, and we recommend you use neural monitoring.
Yep.
Yes.
Can I show
So
them up close?
yeah, go ahead. So
talk
this is
about
a trephine. It has a cutting tool at the tip. It has a serrated tip. And so what we're doing there is we're at the annulus, and we don't want to push the annulus open with the dilator. We want to pierce through it. And if you use a dilator, what you could do is increase intradiscal pressure way too much. So you really use this just to make your annulotomy, cut through it, and it makes this very easy. All you have to do is slide this down, and as you turn clockwise and push, you're just
Nice.
going to pop through. So if you guys want to, you want to take a
Yeah,
feel
I do.
what that feels like,
I do.
go for it. It's
I gotta
it's a
start,
fun
I gotta
thing.
start doing this in my practice,
You
like
do.
right away.
Shot?
You just
Yeah.
pop through.
You'll
It's
see
very,
it's
very
yeah.
small.
I'm
Yeah.
not gonna lie, Jennifer, that felt like an
She did a good
annulus.
job.
That felt like an annulus. That was pretty
Jennifer's
good.
head's already getting big enough. Let's not
Yeah,
drag
no,
her too much.
someone else did it.
All right, she did an awesome job, no question.
So we've made our annulotomy. We're gonna place our dilator back in. And basically now we're ready to enter the disc.
Awesome.
So this threads in unlike the trephine. So they connect and you take them as one unit and push through that disc.
Yeah.
Yeah, you can feel like that resistance, It's a good resistance there. You definitely feel it.
Oh, for sure.
You feel
Yeah,
that, right?
oh,
Yeah,
yeah.
how it grabs on
Oh, yeah.
very
Nice.
well, firmly in the disc.
Not moving.
Now, you're well into the disc with the cannula, so you can remove your guide wire and your dilator together, because
Okay.
And now
everything's
you're
in.
working cannula there.
Right,
basically, right?
right. And so let's take a shot. Let's see where we ended up. You're a little too far. You don't want to take disc material out in the middle of the disc or in the anterior.
You want to
third
be posterior.
You want to be in that posterior third of the disc. Exactly. So let's bring this back.
Very nice.
And so, yeah, you're right. It really grabs on. So really gives you the ability to kind of understand, it's not loosey-goosey. It's good. So this is kind of the limit as far back as we want to go.
Yeah.
Okay.
But if we put in the pituitaries and you slide these in, and so basically,
This was a little bit like surgery now.
right?
Yeah.
Yeah.
Feeling very surgical.
Yeah.
Slide that in, enter the disc, and I can open this shut. You can see,
Look at
you
that.
can take huge bites of disc material
Yep.
through a very small cannula.
Yep.
That's
Let's
the
see
beauty
if
of
we
it.
get anything out. I'm excited about this.
So we got
Yeah,
something.
we got some foam. Look at
We got
that.
some foam that looks a
Make
little
sure,
sanguineous
make sure to
there.
bill
Yeah.
the patient for that.
Yeah.
The
A
playback
little
beam down here.
Very cool.
heme colored foam there.
Yeah.
Not
that's
bad.
good. Yeah.
I think it's red. That's why.
Yeah. And,
No, that's excellent.
with that, you're going to take about 8 to 10 bites.
Mhm.
That will generally net you about 2 grams of disc material.
Okay.
Which, if you've used a lot of percutaneous needle-based discectomy kits, that's a lot of disc material. It's hard to take out a gram of disc material with, say, something like just a decompressive needle, right?
Mhm.
Now you've created your cavity, you've taken out bites, and usually I'll turn that around and do clockwise bites.
Okay.
Now you can place the trigger flex. Now the trigger flex,
And this is plugged in to the generator here.
yep.
There's a foot pedal over here that you guys can't see, but
I'll pick it up.
it's like a hand pedal.
Oh, I just want to show everyone.
Yeah.
There you go.
Go
So
ahead.
you have 2 different modes here, right? So you have bipolar turbo, the black, and then the hemo bipolar. So this is what you use when you want to use this tool to break up and vaporize nuclear material. You want to make a bigger cavity. You want to soften up a degenerative disc. This is a much higher temperature and a lot of energy. This is when you want to rake this across the annulus. You don't want to remove annular material, but you want to seal those tears, right? So this is lower energy. So that's the purpose of the two pedals. And so what you'll do is you'll take your trigger flex, and basically I find it more comfortable, you know, if you're right-handed, you come on the other side of your fluoro, and now you slide this in, and you squeeze it down, and you can see you have a lot of range. You can cover a huge cavity with this.
Yeah.
And basically, you're going to hold down that black pedal, and you're going to squeeze this for about 3 seconds to get the whole tip out. And then for another 3 seconds, you're going to open it up. So it should take you 6 seconds to open and close it. But it's really slow. It's a very controlled approach. And what you're doing is you're ablating nuclear material as you go in and as you go out. Now, this technique is called 6 for 6. I called it this because for 6 seconds, I'm going to go out at 12 o'clock, and I'm going to do it 6 more times.
Okay.
So I'm going to do it at 12 o'clock, 2, 4, 6, 8, 10.
Okay.
And so that's going to create this cone of vaporization within your nucleus. And after this, you're going to be able to place a scope in, and you're going to see the cavity that you created. You're going to document it. You're going to observe it very well.
Yes.
So I think it's fantastic for that. Now, the next step, you've finished your work on your nucleus. Now you want to work on your annulus. So you're going to take the tip of this and raise it up so the bevel is up.
Okay.
So they have a non-bevel. This is a non-bevel, and they have a beveled cannula. So you can use both. And I prefer the beveled one because it has more surface area. So you push that down to get you closer to the annulus. You squeeze this, and now basically what you're doing is you're squeezing this and raking this across the annulus.
Okay.
And you're going to go real slow. And as you do it, if you have gradable tears, you're going to feel the point of this kind of fall into the tear.
Okay.
And you're going to rake that, and you're going to hold down the blue pedal, right? And so basically, we'll take about 3 passes. We'll keep it down. We'll slowly rake it.
Can you go live while we're doing it real quick?
You're slowly raking this across the annulus. You're going to take about 3 passes to finish that. And now you have completed pretty much the surgical discectomy and annuloplasty portion of the procedure. You can now go in with the same needle that we used to start the case. Yep, there you go. And what I'll do is I'll take about 40 cc's of saline, and I'll put this all the way down, and I'll pulse irrigate all of the debris out, all of those little bits of disc material, and it will hopefully fix any aseptic discitis that patient has. So it's great for that. You can pulse irrigate, and then basically you're just rotating this out and pushing this, the bevel or the hub of this up towards the head. So I keep it away from nerve root, needle goes down, and just slide that out, and there you go.
Amazing.
So
no stitches, no staples.
I don't suture. It's a less than ½ inch incision.
Yep.
It's really small. They close up great.
And
Patient rests for 2 weeks.
do you give them a brace? Yep.
Absolutely.
Yep.
So that 2-week period is a perfect time for herniation. And I did have a lady, she's a pharmaceutical rep. She got 100% better after I treated her. And the discharge instructions are very clear. Right?
Don't do anything.
Don't go drive around. And what a pharmaceutical reps do, they drive everywhere. She gets back 2 days later, gets back in the car, re-herniates. And we don't recommend reoperating with disc fix on a previous disc, right? So she had to get open surgery. So she's a perfect case of someone who didn't keep the disc.
I think like a lot of these other procedures we talk about, this gives us another option before big open surgery.
Sure.
You just said 2 weeks with an LSO break. You have big open surgery. We do those at our place. It's 6 weeks at least,
Exactly.
if not 12 weeks
Right.
of inactivity, no bending, lifting, or twisting. Most people can't even work because a lot of their jobs are a little more physical. So,
100%.
So one of the things that's really critically important here, and I'm going to go from back proximal. So you mentioned looking at this with the scope. So the codes in this are 62287, 62380, and the first code is the percutaneous code, and the second code is the endoscopic code. Without the endoscopic code, it's a no-go. It's a non-sustainable procedure. So number one, just remember that 62380. The other thing too is this is not new. There's plenty of data. There's data from Kumar, Arano, Malik, Hellinger that really shows very nice pain reduction and functional improvements. And so the one from Arano actually is a Japanese paper that shows you can use the scope not only for purpose of coding, but you can use the scope to make sure that your area of evacuation is adequate. And this for the patients who got the scope improved significantly more than those who did not.
Mhm.
And so there's, I mentioned the 4 papers, there's, 10, 12, so there's adequate literature support for this. For patients, apart from this, there is, you could go up from this, you can go through an EAD, endoscopic assisted discectomy code, but this is through a bigger system. It's a little bit more really, it requires a tower. And don't do that unless you really are in endoscopic procedures. But this is very accessible and it provides things that's, akin to pituitary rongeur, right? That's exactly what this is. And you can take out real disc material with this. And so this is
And really do a decompression. I think that's the biggest thing.
and maybe the secret sauce is the temperature. So you start off at 12 o'clock and do the points of ablation at the even numbers. But this is very similar, and this has been well studied. So the collagen for the annulus, it all tightens up about the same. The higher you heat it, the faster it tightens. And so it also will ablate the nerves that grow in from the base vertebral nerve. The sinuvertebral nerve is so it comes off the DRG. The sinuvertebral nerve comes off, innervates the posterior portion of the disc. Nerve growth will go in. This will help ablate it. And the branch of that is what we talked about earlier, the basic vertebral nerve ablation.
Mhm.
So this is something that's very useful.
Doug's absolutely right. If you want to look at some great surgeons who've been doing this, Tony Young's kind of the father of endoscopic discectomy, or one of them. And then Glenn Choi is also super famous. There's some great articles, real wizardry of neurosurgery there. If you want to do endoscopic discectomy, this Disfix tool is a great base learning opportunity. And so we really, really recommend that you know how to do a great transfemoral epidural steroid injection, know how to do discography, look at your own MRIs, and then come to the lab, learn more about this.
Awesome.
Yeah.
AJ, that was awesome.
That was
I'll be
amazing.
honest with you guys.
Do you have
When I
any
come to
questions?
these combines,
Yeah.
I'm open to learn something, and this
This is
was one of the things
amazing.
I was really looking forward to. And you did a fantastic.
Do you have any
presentation.
questions there, Ryan?
Yes.
Yeah, so,
I think we have some questions for AJ and
Yeah.
I think you answered it a little bit, but are you doing endoscopic procedure awake?
Yes. Yeah. So light sedation, a little bit of Versed, a little bit of fentanyl. We don't recommend propofol unless you're going to do neuromonitoring, because your patient awake is going to be your biggest safety measure in terms of making sure that you're not too close to nerve root. And also when you do the heating portion of the procedure, when you're intradiscal or you're close to the annulus, if they feel the heat, there are no nerve endings in the nucleus. They feel that heat, you need to stop there because that heat is being transmitted to neural structures.
And then the last thing is, how big is the incision? 70 millimeters?
The incision itself is probably less than half an inch. It's a very tiny, almost like a stab incision.
you just put steri strips and pressure
Exactly.
dressing, right?
Exactly.
There's not even a stitch
Yeah.
or a staple.
I stopped suturing these a long time
It's
ago.
it's a number 11 blade stab incision. Exactly the same as for BV ablation. It's too small to close with a suture or staple.
Exactly. Awesome, man.
Thanks, guys.
Hey, thank you so much for coming.
Appreciate it.
That was amazing.
Yeah.